Good morning, everyone. One more lecture about renal vascular diseases. Whatever we had done now, tubulointerstitial diseases, and whatever we like glomerular diseases, and all these things, and whatever we are going to do further, renal vascular diseases. The end result is either acute kidney injury or chronic kidney injury. So that's the reason. Once we will finish these topics, then we are going to discuss acute kidney injury and then chronic kidney injury or the chronic renal failure. And in the end, we are going to discuss that. So, of course, like we are going on that, we are going towards that. So, simply, the diseases which affect renal blood vessels, they cause renal ischemia, and that renal ischemia may lead to again either acute kidney injury or chronic kidney injury. Actually, acute kidney injury or AKI or chronic kidney injury CKI are basically new terms because before they were called as acute renal failure or chronic renal failure. But because some of the times, by the way, most of the times, acute kidney injury is reversible. So that's why it is not called as, like, they changed the name to AKI. So, of course, like whenever there is vascular disease of the kidney, they can be a cause of secondary hypertension. And what are the causes, what you can say, which can cause vascular diseases in kidney? Two conditions which are very prevalent these days. One is atherosclerosis, and the other thing is diabetes mellitus. And nowadays, because the life expectancy of the people are more, like before hundreds of years, people don't live this much. But nowadays, because the life expectancy is more, so now there are more age-related problems or age-related diseases. So, renal vascular diseases can be uh, classified or classification or the types of renal vascular diseases. They are classified as or can be divided into groups like large vessel diseases as well as large vascular diseases as well as medium vessel diseases or small vessel diseases, right? So when we will see, it is more like a classification, by the way. So when we are going to see what are the things which occur in large vascular diseases, see, number one, there could be a infarction, so acute renal artery occlusion, which will lead to infarction, or because whenever there is occlusion and there is no blood supply at all, so of course it will lead to infarction, same like myocardial infarction. And then there can be renal artery stenosis, which will lead to, this is stenosis, so it will lead to ischemia. And then there is renal vein thrombosis. Okay, so these are some of the types which we say as large vascular diseases or large vessel diseases. Of course, like they are affecting the large vessels. Then there is medium vessel diseases. So one of the condition is Kawasaki disease, which you had done in pediatrics, and one is called as polyarteritis nodosa. I will try to cover this polyarteritis nodosa in rheumatology, right? And small vascular diseases are too many. For example, the people who have hypertension, they may have hypertensive nephrosclerosis, okay, as well as there could be atheroembolic renal disease. There could be thrombotic, the thrombus is there, microangiopathy, there can be a disease called as scleroderma, and for example hemolytic uremic syndrome. Like all these are vascular, small vessel diseases. So of course, like they are also the cause of, you can say, uh, renal failure. Okay, or like they can also cause secondary hypertension. So of course, like we are going to discuss them one by one. Okay, we are going to discuss, of course, the large vascular diseases, as well as there will be a small discussion about the small vascular diseases. If you will see, like the medium vessel diseases mostly are what you can say will be covered later. Okay, so first of all we are going to discuss infarction. Okay, and then we are going to discuss stenosis, and then we are going to discuss the third thing. Now, renal artery occlusion or renal artery occlusion, which will lead to renal infarction basically. Okay, what is the causes of this thing? This is more like a surgical topic, but again, there can be many reasons by which the artery can be occluded. It could be trauma, like abdominal trauma. It could be due to surgery. It could be due to embolism by infective endocarditis or anything. It could be due to vasculitis. It could be some external compression, or you can say renal artery compression. Like compression can be caused by anything, a ureter, a tumor, anything can cause compression. It could be a hypercoagulable state in which like there is hypercoagulability in the body, and of course like it can cause renal artery occlusion. It could be aortic dissection when of course like this dissection is going all the way through the renal artery. And most of the time, the people who get renal artery occlusion are basically after the renal transplant patients, they get this thing. So now the important thing here is what, um, whenever the patient have renal artery occlusion, so of course the sign and symptoms will depend on what is the thing which is causing renal artery occlusion. The sign and symptoms will be different in renal artery compression, will different in for example, if there is vasculitis, there could be fever. Okay. For example, again, if it is some sort of infection, so there could be the signs of infection. But generally, there will be fever, there will be nausea and vomiting, there could be flank pain. Okay, like this is the pain which most of the patients, they had when they have some kidney condition. So this is the important, like these are the few symptoms which we may have. Of course, like and rest, of course, depending on what is the thing which is causing renal artery occlusion, we will get the symptoms related to that. So now, anyone who have renal artery occlusion, of course, the kidney will be infarcted, and as the kidney is infarcted, it will give rise to many problems. So maybe there can be hematuria. Okay, maybe there can be um, other symptoms as well. But the thing is, simply whenever there is no perfusion to the kidneys, so the kidneys will shut down, and it will lead to acute renal failure, of course. Okay, sometimes the occlusion can be bilateral. In that case, of course, there will be both of the kidneys will be shutting down. Okay, all together. So that's the main issue in this one. So now a very important thing is whenever there is renal artery occlusion, or infarction, the patients, a very important sign is like they present with acute onset of hypertension. Okay, why? Because or if the patient is already hypertensive, so there may be worsening of hypertension. Why? Because of occlusion, there will be activation of what system? What is the thing when the kidney is not getting enough blood? What the kidneys do? They sense it like there is less systemic volume, so they started making or activating the renin, angiotensin, aldosterone system. Okay, so of course, like when renin, angiotensin, aldosterone system will be activated, there will be hypertension, and the patient, or if the patient is already hypertensive, so maybe there will be worsening of hypertension. Okay, so of course, like this thing will be there. And now the thing is, if one of the kidney is functioning, so maybe we will not see like the creatinine is raised, but of course, like if it is bilateral, so of course both of the kidneys will be affected. So how we investigate these patients is we can do a investigation. Of course, like investigations could be many, like to check all the things, right? Of course, you can do clotting studies and all this stuff, but like of course, I'm just uh, talking about the you can say this topic oriented investigations. So uh, the gold standard, you can say the best test or the most reliable test is renal um, arteriography. Okay, of course, like renal arteriography will show that there is no uh, blood supply to the kidney, right? So this thing is the best test we can do. Other investigations which are there is like we can do a CT scan, a contrast enhanced CT scan, or we can do like magnetic resonance or MRI or MR angiography. Okay, can be done simply to check what is the condition of the blood supply. Okay, and nowadays Doppler studies are also there. Okay, so Doppler studies, of course, like they can tell you either there is blood supply is going to the kidneys or not. So Doppler studies can be done in these cases. Now, one of the thing, of course, like you can do urine analysis, you can do CBC, you can do urea creatinine, and all these investigations you can do because all these investigations are related with the kidney function, right? So we can do these things. We can do coagulation studies and all this stuff. So, of course, because depending on what is the thing which is causing this thing, so we can do like the, of course, like what is the clinical picture, what are the signs and symptoms, what is the history. For example, the patient maybe is a known patient of some hypercoagulable state, so of course, like you will decide your investigations related to that. One thing, um, one of the thing is like we check the LDH. So when LDH is raised, okay, especially for example in these patients when the LDH is 4 times, you can say the upper limit, 4 times the upper limit of normal, and you found that the AST and ALT are normal, and you know what is AST? Aspartate transaminase or alanine transaminase, uh, which are for the liver markers. So of course, like if they are normal and LDH is very much raised, especially like 4 times the normal limit or upper normal limit, it is highly suggestive of some kidney issues, right? So this thing is the investigation of choice. So how we treat these patients, what can be done for treatment now is simply treatment depends on the cause, right? So of course uh, it's a emergency, and if we can quickly uh, diagnose the condition and take some action, of course we can save the kidney function. Okay, what are the things which can be done? There are many options available. For example, anticoagulation can be done. Okay, as well as you can say thrombolytic therapy can be given. Okay, thrombolytic therapy can be given, or percutaneous angioplasty can be done, depending on the cause, of course, or we can do clot extraction. A clot extraction, like we can take the clot out, or a very invasive type of thing, but surgical embolectomy can be done. Okay, for these patients, of course, like to take out the clot and fix the condition. If the patient is having hypertension after this episode, of course, what can be done? What should be done is like we can put them on a antihypertensive drugs. Okay, so this is the important topic. Uh, Other topic which is like the important one, or you can say, at least in my view, which is more important than this one, this topic is uh, the ischemic condition, which is renal artery stenosis, right? So remember, in what you can say, in renal artery occlusion there is infarction, and in renal artery stenosis there is ischemia, right? So this is the major difference between renal artery stenosis and renal artery occlusion. So now, renal artery stenosis, basically there is ischemia, and it presents clinically as hypertension. Okay, of course, if it affects just one kidney, or if it is affecting both kidneys, of course it will present as a renal failure. So it present as hypertension if unilateral, okay, if unilateral occlusion is there, or you can say a renal failure in bilateral cases. Okay, like when the both of the kidneys are affected, of course it will present as renal failure. So why there is hypertension? Again, if you know how the kidney function, the answer is very clear. Whenever there is less blood supply to the kidney, so what will happen? Renin, angiotensin, aldosterone system will be activated in response to less blood supply. Okay, and of course, like, it will lead to hypertension in the patients. Okay, so now the important thing is in this one that renal perfusion is dropped. Okay, and RAAS system is activated. Okay, of course, and angiotensin no and the angiotensin 2 mediated glomerular efferent. What happens, like, angiotensin 2 basically causes the efferent arterioles constriction. Okay, so there is vasoconstriction or arteriolar vasoconstriction by angiotensin 2. Okay, so which basically try to maintain the GFR. So now one thing, whenever there is hypertension, we use one of the drug called as ACE inhibitor. Okay, angiotensin converting enzyme inhibitor, which basically shut down the system. So um, now uh, what happens many times, though it's not very good way of diagnosis, like if we will give ACE inhibitors in these patients uh, who have renal artery stenosis, right? So when we give them ACE inhibitors, what will happen? That ACE inhibitor will shut down the system, RAS system, and when RAS system is shut down, what will happen? There will be less blood supply to the kidney, and what will happen? That GFR will get down. Okay, so it's not a good diagnostic method, but a very important thing. Remember, like, if you, like, take it in this way, if someone GFR or renal functions become worse on starting ACE inhibitors to them, then think about renal artery stenosis. Okay, so very, very, very important point. So now, um, like, again, as I told you, that it can lead to like, if it is bilateral, it will lead to renal failure, and if it is unilateral, the patient present with hypertension. That's the clinical presentation I'm talking about. So guys, it is an important topic because it is a cause of end stage um, renal disease, okay, or ESRD. End stage renal disease is also called as ESRD. Okay, so it is a cause of ESRD in 15% of the patients. Okay, so uh, a very common cause of, you can say, end-stage renal failure. So now, what are the causes of this renal artery stenosis? Very easy. Remember, atherosclerosis is the most important cause. In 90% of the cases, this is atherosclerosis which is causing this thing. And there are some risk factors, like, whenever it is atherosclerotic plaque, now most of the time in the history you will find that it's a male, and you can remember these three things: male, age is more than 55 years, okay, and a smoker. So these three things, higher chances of this one, okay. And in 10% of the cases, it could be fibromuscular dysplasia, okay. In 10% of the time, this is the cause of this condition, okay. One more thing, that whenever it is atherosclerosis, it affect the proximal 1/3 of renal artery. Whenever it is fibromuscular dysplasia, it affect the distal 2/3 of renal artery, or any segmental branches. So now, whenever it is fibromuscular dysplasia, remember, it is females most of the times, okay. And the other thing, their age is less than 30 years of age, so quite young females, they present with this condition. So now, the same point which I told you, if you know how renin, angiotensin, aldosterone system works, so you will be having a very important, what you can say, concept about this condition. So simply, um, the GFR is dependent on angiotensin 2 induced efferent arteriolar constriction. Okay, so simply, whenever there is stenosis, what happens? See, stenosis will lead to what? The stenosis will lead to simply reduced renal blood flow. Okay, there will be reduced renal blood flow, and when the renal blood flow will be reduced, what will happen? That the GFR will be reduced. Okay, and what will happen? Like, the kidney will sense, or which cells will sense? Basically, you can say, there will be efferent arteriolar constriction. Okay, due to what? Due to angiotensin 2. Okay, so due to angiotensin 2 activation. Okay, so this is the thing. So due to this constriction, what will happen? There will be rise in GFR. Okay, so this is the whole mechanism, and that's the reason if we will give them these ACE inhibitors, which will shut down the system, their GFR will be reduced. Okay, so this is the most common cause of secondary hypertension as well. Okay, secondary hypertension, like, this is the most common cause of secondary hypertension. So simply, if you know, again, RAS system, easy to understand. Okay, so basically, angiotensin raises blood pressure in two ways. It causes generalized arteriolar constriction, and it also releases aldosterone, which basically retain more and more sodium and more water. Okay, so this thing is important. So now, what is the thing? The risk factors, right? You know the risk factors of atherosclerosis. The risk factors of fibromuscular dysplasia. Okay, and also, like, check their lipid profile and all this stuff. So the sign and symptoms are, like, not too much, rather, you can say, of course, the patient will present with hypertension. Okay, now this hypertension can be very severe, or you can say hypertension will be severe, as well as it is refractory. Refractory means what? Like, you you are giving drugs, but there is no effect. Okay, there could be hypertensive crisis. Okay, like, we had done this hypertension topic, and I told you what is that. So now, this is the thing. The patient can present with what you can say, other non-specific symptoms. Basically, this is the most important symptom you can remember, because rest of the things are which will come on investigations. For example, when we do investigations, what we can found is okay, on examination. Yes, there is a very important point. Maybe though, like, not uh, always, but maybe there is a renal bruit. Okay, because there is stenosis, and uh, like when you put the stat almost a little up, or like towards the upside and towards a little lateral from the umbilicus, if you will auscultate, maybe you will hear a bruit in these patients. That is, due to stenosis. There is blood supply through a narrowed space, which produces this sound. Rest all the investigations, or the findings are basically on what you can say when we do investigation. For example, see, the investigations, what we will do, of course, like, again, I will talk about the topic oriented investigations, though the investigations can be many. For example, you must check the lipid profile of the patient, because atherosclerosis is there. But for example, if when we will do ultrasound, the kidney size is reduced, or small kidneys can be there, okay, because the kidneys, they shrink in size, as well as renin angiotensin aldosterone system is activated, so maybe you will found hypokalemia, okay, because sodium will be retained and potassium they will lose, so of course hypokalemia can be there. So this thing is important. And one test which I told you, though it's not so sensitive, but when we give them ACE inhibitors, so what happens? GFR reduced and creatinine will raise. So creatinine will be raised after or with ACE inhibitors or angiotensin receptor blockers, right? So this thing is very important thing to remember, okay, about this condition. Rest, of course, like, to establish like the stenosis, you can do many investigation. Of course, like, you can do the same investigation which we talk about in the previous one. You can do Dopplers, okay, or duplex Doppler studies can be done, and it's a very good screening test, by the way, because it will tell you how much blood flow is there. And you can also do digital subtraction angiography, okay, as well as you can do CT or magnetic resonance angiography, okay. Of course, like, our all aim is to see the arteries, okay, how they look like. So these things is important, right? So one of the thing, like, of course, like, they are the non-invasive test, okay, and they can establish stenosis. But when the GFR is less than 30 milliliter per minute, we don't it's not good to give them contrast, okay. So that thing is important. So of course, like, the gold standard to diagnose this test, like these kind of questions they ask on PLAB, it is renal arteriography, okay. Of course, like, because it will exactly tell you how the arteries they look like, right? So this is the thing, or this is the investigations which we do in these patients. So all these investigations are very important, okay. And when it comes to the management, so first of all, you must be what you can say taking care of the hypertension, okay. So the uh, treatment for renal artery stenosis starts with uh, like, the exact treatment is, of course, surgical, right? Because it is stenosis, so you must uh, deal it surgically. So what are the surgical options which are available? Percutaneous uh, angioplasty can be done. It's more that's why I told you it is more or less like a surgical topic. So with, of course, with or without, we can put a stent, okay. If we can do surgical revascularization can be done in these patients as well, and or we can do surgical bypass grafting, which we do in the heart as well. So again, that one is can be given as this one. So now uh, guys, a very important thing in this one, uh, to control hypertension, ACE inhibitors, okay, is the drug of choice. Okay, is the drug of choice because this is the drug which exactly go and grab what is causing the hypertension. That is basically the activation of renin angiotensin aldosterone system. Now remember one thing, very very important thing, it is contraindicated in bilateral stenosis. Okay, remember this thing, this is very 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 important point. Okay, ACE inhibitors are what you can say, it is contraindicated in bilateral what you can say, renal artery stenosis. Why? Because see, if there is bilateral renal artery stenosis, and if we will give ACE inhibitors, there will be global less perfusion to the kidney, like the GFR will be reduced too much to the kidneys, which is going to cause more damage than good. Okay, so that's a very important thing. So of course, the treatment should be initiated as soon as possible, because if the kidney size are shrinked, of course, then there is no point of treating them, because then the damage is done, and that cannot be reversed. Then of course, uh, then the only thing is to leave that kidney, or because that kidney we cannot bring the function back, but rather we can do something called as we will try to save the other kidney if less damage is done on that kidney. If it is unilateral, of course, the other kidney is doing the function, so then the problem can be not so much. The third thing is renal vein occlusion. Okay, and of course, like when renal vein occlusion is there, so there will be more congestion. Okay, so most of the time, this renal vein occlusion is occurs due to hypercoagulable states. Okay, like nephrotic syndrome. Remember, nephrotic syndrome is itself a hypercoagulable state. Okay, so this thing, or there again the same story, there could be external compression of the vein due to that, it is occluded. Or if there is trauma, like the same thing, it could be malignancy. Malignancy is important because when you will study malignancy in surgery, the renal malignancy or renal cell carcinoma, it can spread by the renal vein. So when the tumor go into the vein, of course it block the vein. Okay, so that thing is important. Whenever there is renal vein occlusion, guys, the patient present with nausea and vomiting. Okay, remember, like even the UTI, they present with nausea and vomiting. There can be flank pain, there can be hematuria. Okay, and rest is all the same things which we are going to get on investigations. For example, again, LDH will be raised. Okay, in these patients, and creatinine raised. Okay, there will be proteinuria, and all these things will be there, right? So how we treat these patients, how we investigate these patients, what is the um, most important, you can say, investigation? It is, or the gold standard is renal venography. Okay, because renal venography will tell us exactly what is the condition of the renal vein. Otherwise you can do again CT or magnetic resonance angiography, and you can angiography, or you can go for Doppler. Okay, Doppler's ultrasound. So this thing is there, and the treatment is simply, again, thrombolytic therapy can be given. Okay, because we have to bust that clot. We can do percutaneous thrombectomy to remove the clot. Okay, and if it is acute condition, of course, because if the condition is chronic, then there is no need to do that. We can give them anticoagulation. Okay, So anticoagulation, of course, like at least for like 1 year or for all life, depending on what is the cause. For example, if there is some hypercoagulable state which is there, and which is a very common like which is there and affecting the person, so of course like we can start a like anticoagulation for the rest of the life. So other than that, guys, medium-sized vessels disease, Kawasaki or polyarthritis nodosa. Kawasaki you already have done in pediatrics, and polyarthritis nodosa we are going to cover in what you can say um, in rheumatology, right? The other one is like this disease of small intrarenal vessels. Okay, so if I will talk about that, uh, there are many causes of that. Okay, but I will be talking about few. For example, uh, small vessel diseases. Okay, in this one, what I'm going to talk about is, for example, there is hypertensive nephrosclerosis. Yes, the thing which we can cause talk is atero embolic um, renal disease. Okay, so this is one of the conditions which we can talk about. Now, atheroembolic renal disease, what happens, like simply there is an embolus which is obstructing a small or medium sized renal vessel, okay? And of course, like it is spontaneous, or it can be, for example, after surgery, especially, for example, if you are performing percutaneous angioplasty, if you are doing angiography, for example, or if you are performing surgery, maybe a small thrombus can go and can occlude a small or medium sized vessel, okay? So causes can be many. So now the important thing is that whenever these patients have like the patient have this atheroembolic conditions or renal diseases are there, okay, so simply a small type of uh, embolus have went into the kidney, and it have blocked a small or medium sized vessel. And uh, what is the presentation? Again, the presentation could be nausea and vomiting, or maybe hematuria, okay? But most of the things are basically we can found on investigations, again in this case, in this case, okay? So what we get in these patients is, like on investigation we found that there could be eosinophilia, or eosino uh, eosinophiluria. Okay, so eosinophils will be there in urine, as well as what you can say um in the urine and in the blood. So uh, this thing could be the presentation in these patients, right? Now the important thing, it is embolic renal disease. For example, uh, if sometimes the embolus comes from cholesterol, or we call it as cholesterol emboli, in that case, of course, when you will examine the patient in clinically, maybe you will found the signs of increased what you can say cholesterol level, okay, as well as when you will perform the clotting profile, maybe you will found the sign and symptoms related to that, okay. So if it is due to that, when we do renal biopsy in these patients, what we get is needle shaped um, cholesterol clefts, okay. So we can found this thing, okay. And there is no effective treatment for this condition, but to avoid angiographic or surgical procedures, or to treat hypercholesterolemia if it is there, okay. So the prognosis is poor. It leads to end stage renal disease in most of the patients, right? And one more condition is called as thrombotic microangiopathy, okay. thrombotic microangiopathy, or hemolytic uremic syndrome, or thrombotic thrombocytopenic purpura. Like these are the two kinds of thrombotic microangiopathy. So, like thrombotic microangiopathy. So see, there is of course some sort of thrombus which have blocked the small vessel. So the two conditions which can play a role in this one is hemolytic uremic syndrome, again, and thrombotic thrombocytopenic purpura. By the way, both of these conditions we have discussed in pediatrics. Now, what is hemolytic uremic syndrome? See what's going on in that one. There is small thrombus formation in the blood, as well as there is destruction of the RBCs, okay, and all these things. So what happens, like this microemboli can go and occlude the kidneys, and the same thing happens in thrombotic thrombocytopenic purpura. Okay, so what is the thing? Because these small embolus or thrombus basically go and it damages the endothelial cells of the microcirculation. Okay, so what happens, like there is cell swelling, and the platelets get adhered to that, and of course there is uh, thrombosis. Okay, so of course, like you will get the features of same Hus and TTP in the patients. Okay, when you will examine them. So when you will examine them in the labs, of course you will find the things like this. Okay, so these things can cause thrombotic microangiopathy, as well as there is one thing called as disseminated intravascular coagulation. You are going to study this thing in gynae ops, okay, in detail, as well as severe preeclampsia can also eclampsia. Again, it's a gynecology topic, and it can also lead to uh, uh, the thrombosis of small vessels of the kidney. Okay, but more commonly it is Hus or TTP. So uh, when we're, like if we will do biopsy in these patients, what we found is um, fibrin thrombi around the glomerular capillary loops. Okay, we found this thing. So now, how we treat this condition, because the Hus and TTP is the most important cause. So of course the treatment depends on the cause, but mostly you can say supportive treatment is given to these patients. Okay, supportive treatment is given to these patients, and one more thing, like other than supportive treatment, what we can do is, like for TTP and Hus. Okay, if you remember the treatment of that, we can do plasma exchange, okay, to like clear the blood of this thing, or you can use cortico steroids in these patients. uh, of course, like there are some newer therapies as well, which we can give, but remember, avoid platelet transfusion in them, because if the platelets will be more in the kidneys, so what will happen, that it is going to sorry, when the platelets are more in the body, so the platelet will go and keep on attaching to the endothelial cells of the small vessels, which are damaged. So there will be more and more infarction or damage to the small vessels. So that's why avoid platelet therapy in these patients. Okay, because the platelets will go and keep on attaching to the damaged endothelial cells. So this is like one of the type of what you can say, microangiopathy. Then I told you about systemic sclerosis as well. It's a connective tissue disease, and of course, like it can involve the kidney as well, and it's a very serious feature if it do that. And there is, what you can say, there is cell proliferation in the kidney, and the lumen of the small vessels. The lumen of the arterioles in the kidneys, they get narrowed, and that's why we have the clinical features of small uh, vessel involvement, uh, renal vascular disease. We call it as scleroderma renal crisis. Okay, so this thing is there. One of the thing uh, which can cause is calcineurin. inhibitor nephropathy. Okay, so calcineurin inhibitor nephropathy. So if you know what are the calcineurin inhibitors, remember cyclosporine is there, okay, and tacrolimus is there. And what kind of patients get this? Renal transplant patients, okay. Like whenever the patients, they have any transplant and we have to suppress their immunity, we can give them these drugs, okay. Not just these, like of course there are many others. So now, these drugs, again, like which we give uh, in the renal transplant patients, they themselves can cause acute as well as chronic, reversible as well as irreversible nephrotoxicity. Okay, so both of them they can cause. So what happened? Uh, like there is basically decreased GFR due to both afferent as well as efferent glomerular capillary constriction, which will lead to azotemia. Okay, in these patients, and chronically, they like they causes obstruction, or what we call it as obliterative arteriopathy. So like due to that, the patients may have chronic kidney disease. Okay, of course, like it is not so common. Okay, uh, and nowadays, it is very lower because we use low dose of calcineurin inhibitors in the patients, right? So simply, it can cause both acute and chronic kidney injury, right? So these like nowadays, uh, the we use nowadays we use low doses, so that's why the incidence is less. Okay, so in acute form, it causes both afferent as well as efferent arteriolar constriction, capillary constriction, and in chronic one, it causes obliterative arteriolopathy. Okay, so it causes obliterative arteriolopathy. Okay, because it is the arterioles which are affected. So of course, like it will lead to this thing. So the treatment is like we can give them calcium channel blockers. Okay, we can give them prostaglandin analogs. Of course, reduce the doses of uh, tacrolimus or cyclosporin, or even like other immunosuppressive drugs, because all of them, they are nephrotoxic. So that's all about what you can say, uh, vascular kidney diseases, right? So there is one thing called as analgesic nephropathies as well, which basically occur due to the use of NSAIDs or analgesics. Okay, and they, like the analgesics drugs, especially NSAIDs, they damage the kidneys, and they can cause interstitial nephritis as well as tubular necrosis. Okay, acute tubular necrosis is mostly caused by acetaminophen, but NSAIDs mostly caused interstitial nephritis. Okay, as well as vasomotor type of acute kidney injury can also occur in these patients. So anyhow, like that's the end of this lecture, and in the next lecture, what we are going to discuss is acute kidney injury. Thank you so much.